COVID-19 has been with us for over 2 years now, and it has certainly changed our lives. One aspect of this virus has been the fact that many people who have contracted COVID-19 are living with long-term symptoms. We are seeing new studies coming out to help deal with this ongoing health concern, and we are pleased to bring you some of that information today. I'm Gary Fitzgerald, Senior Editor and Communications Strategist for Allergy and Asthma Network. Today's webinar helps Allergy and Asthma Network live out our mission to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. We are pleased to welcome today's speaker, Dr. Purvi Parikh. Dr. Parikh is an adult and pediatric allergist and immunologist at Allergy and Asthma Associates of Murray Hill. She is currently on faculty as clinical assistant professor in both departments of medicine and pediatrics at New York University School of Medicine. She has been passionate about health policy and is on the board of directors of the Advocacy Council of the American College of Allergy, Asthma, and Immunology. Dr. Parikh is a spokesperson for the Allergy and Asthma Network. She frequently makes appearances as a medical contributor on our behalf to NBC, Fox, CNN, The Wall Street Journal, and CBS. Thank you for being with us today, Dr. Parikh, and for sharing your expertise.
Thank you so much for having me. So with that, we'll jump right in. Next slide. So our learning objectives today are basically to recognize the signs and symptoms of long-haul COVID-19, which is official term is PASC, or post-acute sequelae of COVID-19, to review the treatment and management of long-haul COVID-19, and discuss appropriate referrals for long COVID patients. Next slide. So briefly, we'll be going over, the key COVID-19 points, vaccines and antivirals, and then long COVID and the implications. And, we've been talking so much in the last 2 years about acute COVID and preventing COVID and treating COVID. But what has been insidiously creeping up on us is what I and many others believe could be the next biggest public health emergency. And if you can even fathom it, even a greater public health emergency than our pandemic itself. And that's long COVID, or PASC. And the reason being, although so many people focus on the death rate of COVID-19, far more people survive, which is a good thing in one sense, but they're not by any means back to normal. Many people are still living with symptoms, many of which are debilitating, even 2 years later from their initial infection. And we'll kind of go into, what we've been seeing. I personally, you may have seen on the disclosure slide, I have been working with 2 other physicians in a long COVID practice specifically, and we've already seen close to over 12,000 patients since April when we started seeing these individuals. And it's a lot, and I think it's going to be a great burden on our healthcare system. So it's very important for all clinicians to understand it, because these patients are everywhere and they're seeing every specialist from primary care to, you name it. And so, okay, with that, we'll go further. Next slide. So key COVID-19 points, and many of this information, you all are probably familiar with, but it's important to kind of summarize because it helps play into long COVID and the future of long COVID, or PASC. Next slide. So, right now, the predominant strain of COVID-19 is Omicron and its subvariants. It's now in all 50 states. We have 2 antiviral pill regimens that have been approved for emergency use authorization. One which is Paxlovid, the other is Molnupiravir. And so we're in much better shape than we were last year and, of course, 2 years ago. So there's more tools for early treatment. And why is this important? As much as preventing the actual COVID infection stops long COVID and PASC, there's now some thought that reducing that viral burden and treating COVID early not only obviously keeps people out of the hospital and passing away, but it may also have an impact on these long-term symptoms. And while Omicron and its subvariants have been labeled quote unquote mild by the media and many others, we are now seeing a surge of long COVID PASC patients from that Omicron wave in December. So my point being is that even milder, quote unquote, even though I hate that word, forms of the virus or even asymptomatic forms of the virus can still cause these long-term consequences. Next slide. So, the daily COVID trends in the US, so this is from the Centers for Disease Control and Prevention. It's important to pay attention to it, not necessarily, to be gripped by fear or living in fear, but it's important to know as you live your day-to-day life so that way you can protect yourself. I'm sure many people heard that yesterday on PBS, Dr. Anthony Fauci said that the US has moved out of the pandemic phase for now. That's the keywords for now. We could go back into it depending on if hospitalizations and deaths increase. But he made a very important point that the rest of the world is still very much in a pandemic, especially certain areas of the world that don't have access to vaccines and these early treatment options with the antivirals. We often forget how lucky and privileged we are to be in the US. So these are trends. As you can see, that last huge spike was during the time that Omicron came onto the scene. And as I had mentioned a few minutes ago, that we are now seeing the long-term consequences of Omicron. So many got through it fine, with the actual illness, went back to work, etc., but now are experiencing symptoms and now are coming in and seeking medical attention. And as you can see, as of April 24th, 22, that line is low and flattening. But I will just say anecdotally, I think we are seeing a spike in increasing cases, especially in the last few weeks. Thankfully, not in hospitalizations and in deaths and in our healthcare resources. But I personally am seeing a lot more of my own patients testing positive. And again, in asthmatics, it's not mild. I don't care what anybody says, but it is causing asthma exacerbations, even in vaccinated individuals. So you have to be careful, especially as a lot of these mask mandates are lifting and different restrictions are lifting. Please tailor what you do according to your own risk. Next slide. So current cases in the US, again, another nice map from the CDC. So you can see geographically, where all the cases are, generally certain areas of the country. It's not surprising where vaccination rates may be lower or where population density may be higher, we would see higher prevalences of the virus. I know New York City, as just speaking real time, has been seeing quite an increase. I believe we are already up to 14-15% infection rate just over the last week or two. So again, as I've been saying, I've been seeing a lot more of these patients. Next slide. And then again, vaccine coverage in the US. So again, the darker states have better vaccination rates. So, the Northeast, which is dark blue, has, excellent vaccination rates. And then there's certain other areas in the country where the vaccine uptake hasn't been as good. And, sadly, there is a lot of politicization of this pandemic in general and of vaccines. So, again, vaccination is the best way to prevent illness and prevent the long-term consequences of the illness. So, that argument when people throw it at me that, oh, I'm otherwise young, healthy, I probably won't get severe COVID-19. And I said, yeah, you're probably right. But you may very well still get long COVID. We're seeing it in a lot of young, healthy individuals. And from what I've seen, that's enough for me to want to get vaccinated and for my family members to get vaccinated, because I wouldn't want this virus in any form if I can avoid it. Next slide. So just briefly touching on the vaccines and antivirals, again, why this is important. It might seem like I'm beating a dead horse. I know this audience is very savvy to these things, but now studies are starting to look into the vaccines and antivirals in long COVID or PASC. So this is why this topic is important, not just for the prevention of actual COVID-19 disease and infection, but also its long-term consequences. Next slide. So this New York Times has this great coronavirus vaccine tracker that they've had since the beginning of the pandemic, since the early days 2 years ago. And it's a nice way to see all the different vaccines that are currently approved and or in study. And you know, I think just as a scientist, it's an exciting time because we're really seeing scientific innovation, you know, at its best. You know, the whole world has been collaborating to get these vaccines to become a reality. And it just goes to show, you know, when all resources, manpower, brain power is pooled together, what we can achieve, you know, as humanity. I mean, the record time in which we were able to get a safe and effective vaccine is just mind-blowing. But as you can see, there's still a lot of vaccines that are still in development, which I think is a great thing, because as these new variants emerge and as we find that certain people may not tolerate certain vaccines, right, either due to an allergy or other contraindications, it's always good to have options. That's how I feel. So there's still quite a few in phase 1 and 2 and 3. There's 19 that have been authorized in 2 years. That's amazing. There's 12 that are approved and being widely used at this time. So again, a testament to science and the scientific process. And of course, 14 have been abandoned, but that's completely expected in any clinical trial pursuit. You know, some things will work, some won't, and that's why we do the studies. Next slide. So from a CDC report, it said COVID-19 associated hospitalizations among adults during SARS-CoV-2 Delta and Omicron variant, the predominance by race, ethnicity, and vaccination status. So this is from, you know, July 2021 to January 22. So during that 6-month period. And what they found was that SARS-CoV-2 infections can result in COVID-19 associated hospitalizations, even among vaccinated persons, you know. And what is added by this report, you know, we already knew that, but in January 22, unvaccinated adults and those vaccinated with a primary series but no booster or additional dose were 12 and 3 times as likely to be hospitalized. So you're 12 times more likely to be hospitalized if you're unvaccinated, and 3 times as much if you haven't been boosted. And that's important to note because currently only about 30% of the US population has received their first booster, or shot number 3, respectively, as were adults who received booster or additional doses. Hospitalization rates among non-Hispanic and Black adults increased more than rates in other racial and ethnic groups. And this, again, just reinforces what we already knew throughout the pandemic and before, that there are, unfortunately, health inequities, and many of which are due to access and care. And this pandemic kind of just highlighted and showed light on what we already knew, and in why it's so important to kind of level those inequities. And what are those implications for the public health practice? So one, all adults should stay up to COVID-19 vaccination to reduce their risk for COVID-19 associated hospitalization, of course, death. And we need to implement strategies that result in equitable receipt of the vaccinations amongst all people, you know, especially those with disproportionately higher hospitalization rates, including non-Hispanic, Black adults. Is a very urgent public health priority. And I would argue even globally, you know, I think it's in the US best interest to make sure everybody on this planet has access to a vaccine, especially in the day and age of travel, An outbreak anywhere is an outbreak everywhere. So it's in everyone's best interest to make sure everybody is protected. And this just glaringly shows how important vaccinations are. The data is very clear. They're clearly very effective in keeping people out of the hospital and worse. Next slide. And then again, there was a CDC study on vaccine effectiveness. So they found that there was waning 2-dose and 3-dose effectiveness of mRNA vaccines against COVID-19 associated emergency department and urgent care encounters and hospitalizations among adults during periods of Delta and Omicron variant predominance. And again, these findings, they underscore the importance of receiving that 3rd dose of the mRNA vaccine to prevent, those ER urgent care visits, as well as the hospitalizations. And the finding that protection confirmed by mRNA vaccines waned in the months after receipt of a 3rd vaccine dose reinforces the importance of further consideration of additional doses to sustain or improve protection against COVID-19 associated urgent care and ER visits and COVID hospitalizations. So all eligible people, bottom line is, should remain up to date with the recommended vaccinations to best protect against COVID-19. Now we have 2 that are fully approved. They're no longer experimental. So it is important, to make sure we protect ourselves. Next slide. And now, many centers have been tracking the long-term implications of COVID-19 vaccine on previously infected individuals. And there's a study actually ongoing at Yale right now looking at long COVID particularly, and to see if the vaccines actually prevent long COVID. So are those individuals who are vaccinated either less likely to develop long COVID, or if they do develop it, will it be less severe and hopefully shorter lived? And the goal is to understand the disease pathogenesis behind long COVID. The tool that is being used is to leverage the changes in the immune system that occur after vaccination. So there's a lot of different theories about long COVID. Some people think that there may be persistence of the virus itself, and I will, go more into that in shortly. Some also, and that is driving the inflammation that's causing a lot of the symptoms. Many believe that it's an autoimmune phenomenon, in that the virus itself is triggering almost like an autoimmune disease. And I think that also is a very plausible theory, because if you look at the actual infection itself, it behaves so much like an autoimmune disease. You get blood clotting, you get changes in your white blood cells, you can develop rashes, and it's not the infection that kills you or harms you. It's the inflammation that the infection brings with it. It causes inflammation in your blood vessels, in your heart, in your lungs, all over, head to toe, in your brain. So I think the autoimmune theory is very, very interesting as well. So some of the hypotheses are, again, there's a viral reservoir, that the vaccine may help clear, after the infection, that there are autoimmune diseases that could be triggered by COVID-19. And also the microbiome and the balance of good and bad bacteria is very important. And that may also play a role in this. And those of us who are in the allergy, asthma, and immunology world understand the importance of this, right? We know that this already leads to the increase of allergies, asthma, and other autoimmune diseases, right? As we see in the hygiene hypothesis, and we've seen that trend over the last few decades with worsening allergies, asthma, and so on. And other thoughts are: is there unrepaired tissue damage? And is that what is causing the persistent symptoms, right? Because people come in with long haul symptoms of virtually every organ from head to toe. And then finally, another thought is that there might be reactivation of previous viruses. So there was a study recently done in Cell that was published in Cell, and they were looking at trends that they could find among long COVID patients. And one of them was they found that some of these patients had EBV reactivation. So that's really interesting, because we see that with other immunologic issues too. a lot of our more severe and long-lasting drug allergies, like DRESS syndrome or Stevens-Johnson's, that we've seen that there may be some relation to either EBV reactivation or human herpes virus 6 reactivation. So again, these are all theories, and this is why the studies are important to see what exactly it is, or is it a combination of these things? And virtually every center in the U.S. is studying long COVID and PASC now as a result of it. And it's helpful if we understand what is going on, because then, of course, we can develop the appropriate treatment and management. Next slide. So the COVID-19 antivirals, what do they do? So the antiviral medications, they help your body fight off viruses that cause disease the same way, an antibiotic helps you fight off a bacterial infection. They reduce symptoms of a viral infection, and they shorten the length of a disease, of illness. In most cases, viruses clear up even without these drugs, but when we have a severe, or a novel virus where our immune systems are not used to it, or if you're a high-risk individual, these antivirals may be necessary, right, to help you clear the disease. So there's 2 that are currently approved for emergency use. One by Merck called Molnupiravir. It prevents 30% of death and hospitalizations if taken early, and it's currently available for adults 18 and older. So it's not for use in children due to growth concerns, and it's also not for use in pregnancy for the same reasons, that there might be an impact on the developing fetus. And this is a 4-pill-a-day course taken over 5 days, taken twice a day. So it's, everyone calls it, a COVID pill, but it's many pills. But still, it's well worth it, especially if you take it early, if you're a high-risk individual, because it's easy to take. It can be prescribed by your doctor, just like any medication, through a regular pharmacy, and you can start it right away. Prior to these pills, all we had was the monoclonal antibody infusions, and those were very difficult to obtain, because they're costly. You have to go to an infusion center, you have to, qualify. So there were so many barriers and hurdles just to get that early treatment previously. The other pill or treatment is called Pfizer. Is by Pfizer, and it's called Paxlovid, or the generic name is Nirmatrelvir, and it's actually also combined with another antiviral, which we accidentally left off the slide, called Ritonavir. So the Pfizer drug is actually, you're taking 2 pills over the course of 5 days, and the Nirmatrelvir, I can never pronounce that, is the one that actually helps fight the COVID virus, decrease that viral load in your body. And what the Ritonavir does is it helps work with the first antiviral drug to keep the levels high enough while your body has a chance to fight it off. So the Ritonavir medicine actually has been around for many years and has been used in other instances, in other viruses too, such as HIV. So again, it's 2 pills in one. The efficacy is quite good. It prevents 89% of death and hospitalizations if taken early. And remember, these trials for Pfizer and Merck were done pre-Omicron, but still, very effective. And it's available for ages 12 and older. So this one actually, the children who might be preteens, adolescents, teenagers, they can take it. And it's also approved for pregnancy, which is great because pregnancy is a high-risk state for any infection, but especially for COVID-19. And the important thing, though, with this is that it may have a lot of drug-drug interactions due to its effect on the liver, and so it may be contraindicated in certain conditions. So it's very important that you work with your doctor who knows all of the medications that you are on, just to make sure you receive the appropriate medication and the correct dose of it, because if you have any kidney impairment, the medicine dose has to be adjusted, or if it interacts with any of your medications, either your doctor may advise you to stop taking some of the other medicines for a couple of days while on it. But this also, both of these, they must be taken early for them to be effective. So in the first 3 to 5 days. Next slide. So again, how they work is very different. We touched on this a little bit, but the Merck disrupts the RNA of the virus itself, so that way the virus stops replicating and stops being effective. And the Pfizer drug actually stops the virus from replicating as well, and then prevents its breakdown, so that what the second drug, the ritonavir, will keep that level high of the antiviral, so it'll stay in your system long enough to stop all that virus and to reduce the viral load. So that's what we mean by prevents a breakdown. It's preventing the breakdown of the first drug. Both drugs are very expensive, but the good news is right now they're absolutely free, and they're being underused. So most governments have paid for them, and I've prescribed them for my patients, and so far nobody has had to pay anything, not even a copay, and it's been very easy to get. And I think we should look into prescribing these more often, because it can help the course of the disease. And again, the reason why we're spending so much time talking about this in a long COVID lecture is because now, these antivirals are being studied for post-COVID, and there are other antivirals being used as well, which I will touch on, that are also being studied in long COVID. Next slide. And again, just briefly, there was a lot of buzz when these vaccines came out about allergic reactions and individuals who may be allergic or asthmatic or have an allergic condition taking these vaccines. But again, the insights from the American College of Allergy, Asthma, and Immunology COVID-19 Task Force, for which I'm a member, these reactions are very, very rare. So statistically, you're more likely to be hit by lightning than have an allergic reaction to this vaccine, and actually most other vaccines, especially anaphylaxis. And so specific mechanisms and inciting antigens agents for COVID-19 vaccine have not been identified, but one thought maybe is that it could be an ingredient called polyethylene glycol, which is in so many different medications. It's in toothpaste, it's in so many things that we use on a daily basis, that majority of the population tolerates it without any issue, even highly allergic individuals. So if there is any doubt, allergists and immunologists are uniquely qualified to guide their patients and educate the public during this extensive vaccine campaign. And I can speak from personal experience, majority of the referrals that I got for vaccine anaphylaxis were actually not anaphylaxis. They didn't actually meet the criteria. There's a lot of mimics of anaphylaxis that might feel like having an anaphylactic reaction, but an allergist and immunologist is trained, to dissect that reaction, and many times we can find out even without testing, or we can come to the conclusion even without testing, just from the clinical history, that it is or isn't a probable allergic or anaphylactic reaction. So, please don't think you can't take the vaccine. Please see an allergist or immunologist, because 9 out of 10 times you can go forward and take the second dose safely. Next slide. So is this the beginning of the end? I hope so. I'm sure everybody else hopes so as well. Dr. Fauci did make that statement yesterday about the U.S. moving out of the pandemic phase. So let's see. We'll keep an eye on the trajectory, hoping that the USA will follow South Africa's trajectory. And cases continue to decline as they did for them post their Omicron surges. However, the even mild cases, as I mentioned before, can put a disastrous strain on our healthcare system and can cause long COVID. And just to add another point to that, even asymptomatic cases can cause long COVID. So again, it's in your best interest to not have any form of that virus. But remember, the glass is half full. We're in much better shape in 22 than we were in 2020. But again, we must still be cautious and tailor to our individual risk levels and those around us. Next slide. So long COVID implications. Now, this is what I know everybody's interested in, or PASC implications. Next slide. So, post-acute sequelae of COVID-19. Now, this is known as the chronic version of COVID-19 versus acute. So, the research is bringing us real data. It's an issue for all ages. Actually, it may lead, to health changes for an entire generation. So, again, even though we clearly saw higher risk for certain age groups, certain disease states for the actual COVID infection, that's not the case with PASC. In fact, we're seeing very young, healthy adults get it as much as elderly individuals with other chronic conditions. I'm even seeing some pediatric cases now coming through. And, these are people that are very fit, like 16, 17-year-old varsity athletes that now are unable to even walk a few feet, So, I'm not saying this to scare people. I'm just trying to give perspective that, this is a whole different animal or a whole different beast than the actual COVID-19 infection itself. Next slide. So, what is long haul COVID? We heard this term a lot. So the actual definition is basically any symptoms that are occurring more than 1 month out from your initial COVID-19 infection. That qualifies as long COVID. So that includes difficulty breathing or shortness of breath, tiredness or fatigue, symptoms that get worse after physical or mental activities. This is actually very, very common, that post-exertional fatigue. Even very simple activities can knock these patients out where they're bedbound or couch-bound then for days. Difficulty thinking or concentrating, that brain fog you hear about, and this isn't something mild. I have patients report to me that they can't even concentrate on watching the TV, which is pretty passive, mindless activity. And I have very high-level individuals, like physicians, that say they have trouble finding words just to speak, so the way that they used to talk to their patients before, they can't even have those conversations. Navy SEALs who, obviously are responsible for a lot of high-level cognitive things in their day-to-day jobs, they are unable to function. Cough, chest or stomach pain, headache, fast beating or pounding heart rate, joint or muscle pain, pins and needles feeling, diarrhea, sleep problems, either in both types of sleep problems, either insomnia or hypersomnolence, meaning sleeping too much, fever, fevers are that persistent, dizziness, rash, mood changes, change in smell or taste, and also changes to their menstrual periods or cycles. Next slide. And, these multi-organ effects are what, lead us to think that, maybe there is, an autoimmune disease or a disease of persistent inflammation. Some people with severe illness have effects over a longer time. Many, if not all, body systems are affected. And, we see this in the children who do get sick, that multi-system inflammatory syndrome, where different parts of the body can become inflamed. And this can lead also to post-COVID infections. So everything from your brain to heart to gastrointestinal tract. And then, the hospitalizations themselves, these aren't quick hospitalizations. So many people, if they do end up in the hospital in the ICU, they can be there for weeks. And this can lead to a post-intensive care syndrome, which means, when a person is in an ICU, they can have PTSD and a lot of, mental and psychiatric illness for weeks or even months after coming out of being in the ICU. There's a term for it called ICU delirium, which can happen with any ICU-related illness. But of course, we're seeing it a lot more due to all the COVID-19 hospitalizations. Next slide. So one study that I was involved with another physician who's a pathologist in California, as well as another anesthesiologist and other scientists, we actually found in a very small group of patients SARS-CoV-S1 protein in monocytes, a type of white blood cell of patients who had recovered from the virus and were having long COVID symptoms. And we found this protein almost 15 months after their initial infection. And this is interesting because I'm like, does this possibly shed light on one of the mechanisms in which is driving long COVID? So since this PASC occurs in 10 to 30% of individuals infected by SARS-CoV-2, we see these symptoms in about 30% of these people. And analysis shows that T cell, B cell, monocyte subsets in both severe COVID-19 patients and in patients with post-acute sequelae of COVID-19. So we don't know, is this in everyone that has long COVID? It's hard to say. Again, we had a very small group of patients, less than 50, that we found this in, but the levels of both intermediate as well as non-classical monocytes were significantly elevated in PASC patients 15 months later, compared to those healthy controls. So people who were healthy, did not have these symptoms, didn't have these high levels of protein still in their white blood cells many months later. So this could be part of the puzzle. Is this persistent viral fragment driving the infection? And that's why many people are interested in antivirals for long COVID. Next slide. So these study patients are stratified by symptoms in our study. So we classified them as mild, moderate, severe, and critical. And, again, those who were in the critical were those that during their acute illness required, ventilatory support, had septic shock, multi-organ dysfunction, like those ICU level patients. Then we had the severe, moderate, and then mild patients were those that were able to recover at home, but had, fever, cough, sore throat, no signs of pneumonia or on chest imaging, no shortness of breath or dyspnea. So we stratified them and wanted to get an idea of, like, did more severe patients have worsening PASC or higher levels of the virus? And that's why we came up with this kind of criteria. Next slide. So what we found was that, these intermediate monocytes remain in circulation due to low CCL4 levels. So a CCL4 is actually a cytokine that's very important in your immune system, which actually helps you kick your immune system into action and make T cells to help you fight off infection. But we found that, many months after COVID infection, these levels remain low in long COVID patients, and they didn't recover. And these same individuals had these white blood cells still circulating around, where normally once an infection clears, you wouldn't have them circling it around. And not only that, we found that this S1 protein of the virus appears to be retained from the prior infection in these infected cells. And it's not the result of persistent viral replication. So we didn't find active virus in these people's blood that just kept going, right, long after infection. This is residual fragments of their original infection 15 months later. So one thought that our group hypothesized is that if we interrupt this pathway, the CX3 CR1 fractalkine pathway, this could be a potential therapeutic target to reduce the survival of these non-classical monocytes that are floating around with the viral protein, because they might be causing blood vessel inflammation. So the data here supports that, the immune response to persistent viral antigens, specifically that S1 fragment that still remains, might be what's eliciting that PASC immune response, and marked by elevation in inflammatory markers, including interferon gamma, IL-6, IL-10, IL-2, among others. Now, these cytokines are all inflammatory markers that go up with a variety of conditions. They're not unique to COVID. But the interesting thing is that in these patients, we're seeing them persistently elevated. So our thought was to try different anti-inflammatory treatments in an effort to help improve the symptoms and decrease the inflammation. Next slide. So treatment. So there is no approved treatment for long COVID or PASC. Many centers are trying many medical and non-medical treatments. Many centers too are looking into things like physical therapy and rehab, which is of course very important, meditation, low impact activities that may help, so these things are important. we were looking into seeing if medications could be used off-label. So already approved medications for other uses could be used in an experimental and off-label way to help patients. So we have a preprint that we've submitted to Nature Communications, and they're reviewing it now. Hopefully it will be accepted for publication, where we looked at 18 patients that we had successfully treated with an antiviral called Maraviroc, which is very commonly used in HIV, but it targets that same pathway that we think might be one of the causes of the long COVID symptoms and long COVID inflammation. And we're using a drug called pravastatin or any statin, which is typically used to lower cholesterol, but we're using it in a different way. We believe a lot of the inflammation from COVID is due to blood vessel inflammation, because some of the cytokines that are elevated are consistent with blood vessel inflammation, such as VEGF or vascular endothelial growth factor, and another platelet activation cytokine called SCD40 ligand. So that's why those two drugs were chosen to see if these patients would improve. So they were followed for some time, and what we found was that these 18 patients actually did improve. They had neurological symptoms, autonomic dysfunction, they had cardiorespiratory complaints, and using this combination of drugs did help. And again, this study is very limited. It has not yet fully been peer reviewed, so stay tuned. And it's also a very, very small group of patients, So the ideal study, remember, you want to see randomized, placebo-controlled, but it's very interesting because we are seeing people get better, so it might shed light on possible treatment options in the future. And again, most of these patients have already had very extensive workups, right? So they've seen cardiology, gastroenterology, pulmonary, allergy, immunology, neurology, right? For all of their head to toe symptoms. And everything has been ruled out, which is the right thing to do, right? Because we want to make sure that we don't assume something is long COVID or PASC and treat it as such, when there can be something very, another diagnosis that can be easily treated. So that's a caveat that I say, that don't assume everything is long COVID either, because I've seen a lot of patients that assume, and then we found other reasons why they're feeling how they're feeling. Either they had a blood clot in their lungs or they had some other reason. So that's also an important note, that, you need to rule out other things first. And some other studies that other groups are working on. So there's an NIH-funded study with research on brain fog. And so in UCSF, they found the cerebrospinal fluid actually contained fragments or viral protein remnants. So similarly to how we found the viral remnants in these non-classical monocytes or white blood cells, this group actually found virus in the cerebrospinal fluid, meaning the brain fluid of these patients that are suffering from brain fog. So it's very interesting. Again, kind of shedding some more credence to that viral persistence theory. Next slide. And why could there be such long-lasting consequences from COVID-19? Again, antibodies, which are molecules that are developed to help protect us from a virus, can sometimes go haywire. So one thought is that a group at Yale and the United Kingdom are working on is that there might be autoantibodies or abnormal antibodies that attack our own immune system. So the same way that we see in lupus, or even, let's say, a food allergy, where we develop abnormal antibodies that we don't want circulating, may be also happening in long COVID, and that may be driving a lot of the symptoms. And these autoantibodies may be even having an effect on our own immune systems, right? Causing us to have inflammation in the brain, lungs, heart. So this is another theory in addition to that viral persistence theory. Or it could be a combination of the two, right? That viral persistence is what's creating these abnormal antibodies that we don't want and that are continuing to drive the inflammation long after the virus is gone. So a study of, infected and uninfected samples discovered a high number of autoantibodies present in infected patients. And the immune system reacts during the COVID-19 virus revealed some autoantigens, and looking at patients with long COVID to determine the effect of antibodies and autoantibodies. And many of my rheumatologic colleagues, as well as myself, are noticing that people's autoantibodies for other illnesses are turning positive after COVID infection. So ANA, which is an antibody that we frequently check for lupus and other autoimmune diseases, we've noticed that people who previously didn't have these issues are now coming back with a positive ANA. And in many cases, it's transient, and goes away, but it's just interesting. And it, again, I think leads more support to this theory that there is persistent inflammation and possibly like an autoimmune illness going on right now with long COVID. Next slide. So, as I mentioned, many different antivirals are being studied. The group I work with is studying Maraviroc, which is an anti-CCR5 inhibitor and a HIV medicine traditionally used for HIV. Paxlovid or other antivirals such as Merck's are also, or Gilead's Veklury, are also being studied in long COVID. Pfizer is not testing it, but other centers are. And there's 2 ongoing studies of the treatment involving more than 4,000 patients that could provide us with relevant data for future studies. And researchers are continuing to uncover nuggets that they hope will solve long COVID. And I was told by another patient, and I saw this on the news as well, that Cleveland Clinic is using another antiviral called valcyclovir, which we typically use for herpes or shingles infections, because again, there is that thought that this may be due to another virus being reactivated, like EBV or HHV6, which may respond to valcyclovir. So it's in many different centers are using different antivirals in this regard. In February of 2021, the NIH actually launched a 4-year study backed by $1.15 billion in funding, and to look at long COVID. And in this study, so far, they found that autopsies of 44 individuals who perished from COVID or who were infected show that the virus can last in widespread parts of their body, including the brain, for 7 months after infection. So again, more leading to that viral persistence theory. So time will tell, and I'm glad all this funding and research is being channeled towards answers. Next slide. So, listening to the patient voice, initially a lot of, long COVID was being dismissed because it wasn't filling up the hospitals or causing ICU admissions, but we can't dismiss it anymore because there's a growing number. There's a study with Yale and Survivor Corps, which is a grassroots COVID-19 group that, just based on conversations in social media and Twitter, they found that 40% of people reported mild to full resolution of their long COVID after they were vaccinated. So that prompted Yale to actually launch the study to understand immune responses before and after vaccines, and if that holds the key to learning about long COVID disease, and if that provides an opportunity to design rational therapeutic approaches. So that's why it's so important to listen to patients, because sometimes they can give us clues to help come up with these studies, right, and to drive research. So if you're a patient or someone suffering with long COVID, please make your voice heard. You may have the answer that everybody is looking for. Next slide. And again, the CDC guidance on caring for patients with post-COVID is a multidisciplinary approach. One, identifying these individuals. Please don't disregard them. It is an actual entity. Primary care should work with other specialists. Hopefully, we'll have good laboratory tests to help us diagnose it, and a shared decision making with our patients, with all the providers, to help come up with the best treatment plan. And hopefully our research advances will have good therapeutic and treatment options. Next slide. And again, medical management, this is kind of just, reviewing what we already discussed, but we need a comprehensive management plan. This is a chronic condition, a complex chronic condition. There's many lifestyle components to it. Many of these patients are unable to work. They can't function. They're out on disability, and they're anxious to get back to work. And Some have, we've helped them return back to work, but not everybody, symptomology is very important because, there isn't a very good test to gauge long COVID or severity of long COVID. Holistic approach support for patients. As I mentioned, many groups are focusing on physical therapy, occupational therapy, meditation, counseling, mental health counseling, because a big component of this is a new onset of mental health disorders that didn't exist in these patients prior. And then also, many patients can improve. It's not, the future is not dark, but this multifaceted approach is needed, and special considerations are needed. And there really needs to be a push to study all of these therapeutics, whether it be an anti-inflammatory drug like prednisone or statin or aspirin, or an antiviral, or a combination, or maybe something else that I haven't even thought of or discussed yet. We really need to come up with an answer for these patients. Next slide. And again, appropriate referrals are needed. As I mentioned, make sure you rule out any other causes before labeling someone as long COVID. Obviously, don't disregard patients, but then don't also assume. So working with all specialists is important, and every single medical specialty will be seeing these patients. I can guarantee that. They already are. Next slide. So, future directions, research, learning more about the natural history of the virus, knowledge, updates. The only constant is change, especially in this pandemic. All of us have to be very adaptable to new information as it comes out, both physicians and clinicians and patients. And we have to be willing, to be open-minded and again, follow research, follow data, make sure the information that you are getting is sound and evidence-based, and tailored to your unique situation. So, what works for one person does not work for everybody. And healthcare professionals and patients should continue to check for these updates. Next slide. All right, so I know I talked too much, but there is still 6 minutes left for questions, so I'll try to get through as many as I can.
Yes, thank you, Dr. Parikh, for that enlightening presentation. And yes, at this time, we will be pleased to take your questions. And as it says here, we'll try to get to as many as we can. The first question I'm seeing, what percentage of the long COVID patients that you are seeing were vaccinated?
Sorry, I muted myself accidentally. So that's a great question. So I definitely am seeing more unvaccinated patients than vaccinated. But as I just said on the last slide, that may change because in the last week or two, I've been seeing many more that got sick during that Omicron surge, and these were vaccinated individuals. So now I am starting to see them. It'll be interesting to see, though, the difference in the two groups. I'm hoping that those who, develop long COVID and develop COVID after vaccine, I'm hoping they'll have a milder illness, right? And a more treatable illness and a shorter duration of illness. But yes, the majority of who I've seen have been unvaccinated because they all unfortunately got sick pre-vaccine. Some actually improved then once they got the vaccine. Some unfortunately didn't. And we don't know why. Some improve and some don't, and that's another mystery. So so it's a mix. But as of now, the majority are unvaccinated. But that may change because we are starting to see more from that Omicron surge.
Great. Our next question, why can't the antivirals be over the counter?
Oh, that's a great question. So there are many reasons why. One is that especially these specific ones, like Paxlovid, for example, they have a lot of drug-drug interactions. So actually, and the dose changes if you have any kidney impairment or dysfunction. So it actually can be dangerous to kind of just start taking it without clearing it with your physician or cross-checking it with a pharmacist with the medications that you're on because of all of those interactions. If you see the list of the drugs that it cross reacts with, it's very long. So even things like cholesterol, blood pressure, diabetes medicine, all of these things that many high-risk patients are on, ironically, may have to be adjusted while you're taking this antiviral. And then to throw in that other wrench, that if you have any kidney impairment, then your dose has to be adjusted too. So even though these are great drugs, they're not a walk in the park either. So you have to take them safely.
Thank you, Dr. Parikh. Our next question comes from a patient who had COVID-19 and is experiencing some long haul symptoms. She is in her 50s and she feels like she struggles sometimes concentrating. Her question is, how do you differentiate that it might be mild COVID long haul symptoms or not?
Yeah, so it's hard. It can be hard to differentiate. So if she's a month post infection and these are new symptoms that she's never had before, it very well could be mild long COVID or long COVID itself. I would first, see a physician. And then see if your primary doctor, see if you need a referral for a neurologist or any other specialist that focuses on that, just to make sure nothing else is going on first. And if not, then yes, it very well could be long COVID.
Great, thank you. Our next question, could you talk about skin rashes in long haul COVID?
Yes, that's a great question. We are seeing a lot of skin rashes, especially as an allergist. I'm seeing many people, with hives, eczema, even other types of skin rashes. Post-COVID infection, and all viruses can cause skin rashes, and we see that very frequently, especially in children, but usually they go away once the virus goes away. So the skin manifestations can be a sign of long COVID, and we treat them the same way as we would other skin rashes. So again, with a variety of anti-inflammatory medications. I know my dermatology colleagues are seeing it a lot too. So we use a lot of the same medicines we use for other skin conditions, depending on the nature of the rash and what it looks like, and whatnot.
Thank you. Our next question, is long COVID related at all to chronic fatigue syndrome? And if so, would treatment options be similar?
Yeah, that's a great question. So we've found that there is a lot of overlap actually between the chronic fatigue syndrome patients and long COVID patients. I have a special interest in long COVID, so I've been mostly studying that. But one of my colleagues, he has an interest in chronic fatigue syndrome, so he has been using a lot of the same off-label medications in those patients, and they've actually been improving. So there may be more similarities than we know. I'm not a chronic fatigue specialist, so I can't comment more than that. But I think from what I know, there does appear to be overlap and similarities.
Great. Thank you, Dr. Parikh. Our next question gets into workplace issues with long COVID. Where can people learn about workplace protections and supports for long COVID patients who are no longer able to work normal schedules?
Yeah, I know, I would, speak with your supervisor or boss or, HR company, because now there are a lot of options, either for working from home or reducing your schedule. You may ultimately have to work with your state labor department and seek temporary medical leave or disability, or permanent, depending on how bad the impairment is. But I would first, start with your workplace before kind of going out to the state, because there are a lot of options there, and they'll likely require, documentation by your physician or treating physician. But yeah, there are options out there, because I know I've done a lot of those documentations myself.
Great, thank you. Should a long hauler who got COVID just this past December get their fourth booster now?
Yeah, so if you have long COVID, it all depends on when you had your third shot and what your risk profile is. So Currently, the fourth shot is approved for anyone with severe immune compromise, or immune compromise meaning you're on a drug chronically that suppresses your immune system, or you're a cancer patient, on chemotherapy, or a primary immune deficient patient. You'd have to discuss with your doctor if you qualify, and if you're 4 or 5 months out from your number 3 shot, or if you're 50 and up and have a high risk condition. So for example, all of what I mentioned, plus diabetes, heart disease, hypertension, all of those would put you in a high risk category. And especially if you are, more than 4 or 5 months out from your last shot. So again, everyone's risk profile is different. So it's best you discuss that with your physician, what the best option is. And I apologize that may have to be my last question, because I have to get back to seeing patients, but hopefully maybe we can do a part 2. And if you have any further questions, please pass them along. Usually we try to answer them after the webinars as well.
Yes, thank you, Dr. Parikh, for answering as many questions as you could. And I know how busy you are, so thank you again. And thank everyone online for joining us today. At this time, please download the certificate of attendance from your control panel. If you have any difficulties, please email us using the link in your emails. Please join us for our next Advances in Allergy and Asthma webinar as we discuss access and equity in asthma care. We'll look at the latest research and explore this high-impact health issue. This webinar will be held on Thursday, May 26 at 4 p.m. Eastern Standard Time. You can register for this webinar on our website at allergyasthmanetwork.org. Scroll to the bottom of our homepage to Webinars. And you can also view our recorded webinars on this page on our website. Visit our website for quality guidelines-based resources on allergy and asthma. Also, access important medical information on allergies and asthma from our partners, the American College of Allergy, Asthma, and Immunology at allergyandasthmarelief.org. Thank you again for joining us, and we look forward to having you register to be with us next time on Advances in Allergy and Asthma. This is Gary Fitzgerald for the staff at Allergy and Asthma Network. We're glad you joined us today as we explored long COVID-19. Please join us next time. Thank you.